Dr. Burch, Shane has done tremendous research on outcome data and also studies a lot of he actually created his own database. He contributes significantly our research in outcome, and today he's going to talk about the thoracic shape, kyphosis, and currently he's working on gait analysis, so he's going to give us an update on dynamic assessment with motion analysis.
Well, thanks for that. Thanks, everybody, for being here. It's truly kind of a humbling crowd to speak in front of, especially about deformity, but the conversations are really interesting. So Aleko's kind of tasked me with thoracic shape. Justin just gave a great talk on thoracic shape, but kind of with a twist, assessment with motion analysis. Here are my disclosures. So, all right, so if alignment, we're kind of the dawn of alignment, kind of understanding it. But if we're thinking about thoracic shape, I'd say, as Rusli said, we're kind of still in the shadows. And if we think about how it moves, we're in the darkness. So I'm going to kind of interpret the question here is first question is, so with functional assessment, can we determine the optimal treatment for different shapes of the thoracic spine? That's really kind of what we're asking. And to Mo's question, I wonder where you got that question from. Is it flexible? Is it passive or active range of motion that we're dealing with? And then the third question is, how does the patient move? And really what I'm trying to get at there is, how does the patient bend forward, bend backwards? What are the hips like? Okay, so when we get up in the morning and we have a patient like this, we want to improve their pain, we want to improve their function, so we want to make them stand upright, we want to get them to ambulate with less energy. But what we're really not talking about in any of these talks is their function, right? So does anybody talk about their horizontal reach, their vertical reach? I mean, what happens when they drop their socks on the ground? How do they reach down and get it? And then obviously we want longevity. So we want to avoid mechanical complications, pseudos, PJKs, et cetera. So it's great when, this is one of the cases I got right. Patient's doing really well. And this is kind of what Alekos was talking about. You see 8 out of 10 pain went to 0 to 10 pain in 6 weeks. That's pretty good. And it was maintained for a year. So we got that one right. And I think, Mike's done a great job. Defining the ratio of thoracic spine to lumbar spine is key. It's like the golden rule, and I think it works. And when we apply it to the long constructs, it seems to work. Like you get reduction in rod fractures and reduction in PJK. But the second question is, well, what do we do when we want to stop at T10 or shorter? What are the determinants that will achieve alignment and balance in an unfused thoracic spine? That's the real challenge. So here are a couple of cases. So older lady, and she fused her T10 to the pelvis, dual rods, and again, pretty good results maintained over time. Here's another one. Now, a little bit of thoracic kyphosis, thoracolumbar junction, apex, but managed to realign the spine, balance. The C2 tilt is pretty spot on, and again, over time, did very well, minimal pain. So we can do this right, but of course, we have a lot of cases where we don't do it right, and this paper kind of described the complication rates that we see when we do deformity patients, the 75% complication rate and a 62% PJK rate. So that may demonstrate a lack of understanding of the thoracic spine, and I'm certainly guilty of it as well. So here's an example of cases that maybe I didn't get right. So older gentleman, he's got standing with knee flexion, he's got a high pelvic tilt, got a high thoracic kyphosis, realigned him, thought he did a great job. This is on the table. Look how straight the thoracic spine is. Fantastic, he's gonna do great. That was the post-op film, not bad. And then he, 8 weeks out, he was reaching, and here's the key, he was reaching. He was sitting in a chair reaching to get something off the floor, couldn't reach it, fell over, and got PJK. So just keep that in mind. Here's another gentleman. He's the classic. He's the guy with the hypokyphosis. And you're like, oh, he can extend his spine. So I did a PSO, and this is like literally 2 days after the operation, PJK. This guy can't at any point maintain sagittal alignment. He just has no strength, and I'll get to it later. So shape of the thoracic spine, we'll kind of go through a whole bunch of these. I think Justin did a great job of defining what sort of normal is or neutral is. So I won't belabor the point, but there's a range. And I think that we know that thoracic kyphosis increases across the decades as we get older. Average maybe 45, but there's a huge range from 22 to 66 degrees. But there's different shapes. There's high thoracic kyphosis, there's lower thoracic kyphosis, and there's different inflection points where the lumbar spine goes into the thoracic spine. And typically the upper arc tends to be stable, lower arc is variable. And one of the things that, and I'm not really going to talk on it, but the apex distance from the gravity line. So if you draw a line through the hips, how far back is that inflection point from the gravity line? And of course, I think the one thing that gets it right is the T4L1 hip axis ratio. That ratio is really, really important to appreciate. Okay, so here's some examples. So here's a lady, she has positive sagittal balance. She's got hypokyphosis. Here's somebody with hypokyphosis but is balanced. Here's somebody with normal or neutral kyphosis and is balanced. Here's somebody with hyperkyphosis but balanced. Here's somebody with moderate, you'd say thoracic kyphosis but imbalanced. Somebody with more thoracic kyphosis and imbalanced. And then finally, you get the severity ones. But the one on the right, I'd say that the thoracic kyphosis is not certainly as bad as the one just to the left of it. So thoracic shape is one thing, but it's really how it interplays with alignment that's the most important aspect of this. And so you can't just take thoracic shape and be like, okay, this is what here's the target. So if we break these out, these three that are aligned, honestly, great, they're aligned. They align themselves. If I was, fixing them, I wouldn't really do a lot. I might have a little bit of pushback here, but I wouldn't do a lot because they're aligned. They've actually managed to balance themselves. And that's in contrast to these three where they can't balance themselves. And these are the ones that I really want to ask the question is, can the thoracic spine move? And how does it move? Is it passive range of motion or is it active range of motion? And then how does the patient move? Do they have stiff hips or do they have flexible hips? And really what I mean by that is how long are their hamstrings? So when you put all this stuff together, you got shape, you got global alignment, and then you have T-spine mobility. And when you think about active and passive range of motion, you're really talking about strength. This is what Mo was talking about. And you don't even have to use mobility. It's almost like sarcopenia and frailty are like a surrogate for how people can move. So think about that. And then the hip mobility, I think, really comes into play. And I think now of thoracic compensation being bidirectional. So we think of, okay, hypokyphosis, the patient needs to stand upright, but that's really unidimensional. Like if you have somebody sitting in a chair and you want to watch them tie their shoes, they need to either bend through their hips, and if they can, great. And if they can't, they're going to use some other compensatory mechanism to bend through their hips or to tie their shoes. And if their lumbar spine is fused, well, guess what they're going to move through? They're going to move through the thoracic spine. And so if you prevent somebody from reaching, you're going to get compensatory mechanisms, i.e. PJK. So, compensation occurs in different ways. One of the most interesting studies is that if you ask somebody to walk around, take an x-ray and then ask them to walk around, their kyphosis changed, they fatigue. And so the compensation is a dynamic one. So I did an AI search of all the literature looking at flexibility and motion, and there's really not a lot. There's a sort of great progression through the literature of radiographic parameters, but flexibility didn't really come into play. And if you kind of go through some of the seminal papers, a lot of radiographic parameters, not a lot of studies on motion. And I think that's where we're a little bit limited. So in the next part of this study, I'm really going to talk about range of motion and mobility, and I've kind of broken it down. I'm not really a huge fan of how I've broken it down, but I'm kind of getting there. So range of motion, again, thoracic spine, is it passive versus active? And then mobility, is it flexible versus rigid? And then you can kind of come up with this 2x2 table, but then you kind of want to throw hip range of motion in as well. And I'm going to show a lot of people getting up from chairs and bending forward to kind of explain my point. But here's kind of an example of what really started it. So lady on the, hopefully this will play. Yeah, lady on the right there, she can touch the floor. Gentleman on the left, that's it. Who do you think is going to get PJK? They both have that construct. Who do you think is going to get PJK? It's not the lady on the right. It's the guy on the left, right? It's got nothing to do with alignment. It's got everything to do with how tight patients' hamstrings are. And so I think we have to think about this and how, when we offer patients surgery. So then I started this kind of long journey on motion analysis and set up a kind of a lab in the clinic, camera system. And we have to put markers on the patients, reflective markers, and it turns out to be a pretty complex process. But we're trying to, get our outcomes and our alignment, our radiographic stuff, and understand flexibility and strength as a component of how people do. So here's an example of a healthy volunteer. So flexion extension, surrogate for mobility. So here's a patient, here's a volunteer. This could be me, I don't know. So bending forward, bending backwards, pretty decent. And then sit to stand. You can see how that person activates their quads and stands straight up. And from this, you can get angles of momentum, velocity, acceleration. And I'm not going to go through all the data here. This is more anecdotal, but just give you a sense of what the healthy volunteers look like. The other thing is you can get a sense of how far forward they can bend. So the graphs on the bottom there look at C7 and T1, or shoulders in C7, and the blue line, the dark blue line at the bottom is the pelvis. So some patients can bend forward and they can get their C7 and their shoulders below their pelvis. The one on the right can, the one on the left cannot. So again, something to kind of think about. And then there are studies about how people, kind of move, get out of a chair. And so older patients, some patients can get straight out of the chair like that healthy volunteer can. But there's other strategies that older, weaker patients do. They're called momentum strategies. And the one on the bottom there is the patient has to throw themselves so far forward, they essentially have to flex their hips. They become almost parallel to the floor before they're able to stand upright. And why that becomes important is because if you're sarcopenic and you go through a range of motion, like getting out of a chair or leaning over to get something off the floor, the shear forces and the compression forces on your spine go way, way up. So PJK is not just like standing in a room and a strong wind coming through and like blowing you over. You get PJK from moving, in my opinion. So here's some examples. So this is an example of somebody this is the 2x2 table, who's active and has a rigid. So basically, patient stands up, doesn't really move the thoracic spine, sits down. It's a pretty stable thoracic spine. Here's an example of somebody who's got a flexible spine and is active. So there she is standing up. So a little weak when she stands up. But then when you look at how far forward she bends, she's not getting PJK either because she can touch her toes. And that's her post-operatively. Pain scores are improved. Here's an example of somebody who's got, again, another kind of flexible spine, able to bend forward, and then stands up pretty well. Again, pretty good. Okay, and then in comparison here, in comparison, you have this patient I showed earlier, hypokyphosis thoracic spine. So you'd think, oh, this person's got a lot of strength, but watch this gentleman trying to get out of the chair. Right, you can barely do it. So he has no strength, right? Even though he can flatten his thoracic spine out, he's got no strength. And sure enough, like this is the guy, this is like post-op day 2, he got PJK. Another lady, similar, had prior surgeries, not great protoplasm. Watching her trying to get out of a chair, like, again, trying to use the momentum strategy, leaning forward, high shear forces, barely gets out. Again, I did a short construct, ended up extending her, alignment's crappy, didn't do well. Here's another lady, severe deformity, and I was smart enough not to operate on this lady. But look how she gets out of a chair. So if I'd have gone to, T10 would be ridiculous. If I'd have gone to T3, she would have still had high shear forces and compression forces at the upper thoracic spine. She would have got PJK for sure. And then she can't even bend forward. So she's like the worst scenario where she's not flexible. She doesn't have the strength to be flexible, and she's extremely weak. And if you look at these patients, you look at their muscle in their, on their MRI, like they don't have any. So that's, again, a kind of a surrogate for this stuff. Here's one who's kind of rigid, has some passive extension. And I think I got this right because I extended this patient up to T3. So I took control of the thoracic spine because I didn't think the patient could, and the patient did reasonably well. And then here's an interesting one where patients actually can get out of a chair well, but does not have reasonable range of motion. Like he's really stiff, okay? And then if you look at the outcomes, you can see, look at the ODI scores. Like he did really well initially, and his images on the left were decent, but now he's got PJK. And I think the reason why is because he's compensating with this thoracic spine to bend forward and like live life, and he's breaking down that level. And you can see the ODI scores go up. I haven't reoperated on him yet, but it's coming. And then this is one I think I got wrong because, again, she stands up really well, but I went high on her, and I probably didn't need to go high on her. I probably could have got away with a T10 at the pelvis with her. So my way of thinking's kind of evolved. I think about shape, kyphotic, normal, or neutral, and flat. Are they balanced, positive, neutral, or negative? And then I think about global mobility, and I think about segmental mobility. And I'm kind of trying to come up with, the risk, like which category patients are higher risk at. So if you've got short hamstrings in the hip, you've got a mobile T-spine, you're probably going to get PJK. But then if you have extreme weakness, you're going to get PJK as well. So in summary, thoracic shape is still in the shadows. It changes with age. And I think the compensatory mechanism, we have to kind of move out of a unidirectional thing. It's not just hypokyphosis because you want to stand. You compensate with your thoracic spine to bend forward, to reach for things, to like live life. And we have to factor that into our thinking. But it certainly has an effect on outcomes and complications. So thank you. Yeah, so I don't think you need to have this stuff. I've learned a lot from it, but I don't think you need to have it. I think, honestly, I get patients to just like stand up, bend forward. One of the tricks is to say, hey, bend your shoulders back and bend forward, and you get that kind of like reduces any flexion in the thoracic spine or lumbar spine, and it gives you true flexion of your hips. And if they're like this, you're like, hey, listen, you're going to have issues afterwards. You're not going to be able to tie your shoes. And then there's some people like that lady I showed who literally can palm the floor, right? And you're like, oh, I can fuse you to whatever, and you'll still be able to do that because it's all hip range of motion. And then looking at the musculature on the MRI, and obviously I didn't go into osteoporosis and all that stuff, but all that stuff comes into play. Yeah.
No.
Fred? Oh. I think the hamstring length is like innate. Maybe we should be like clipping people's hamstrings. Like seriously.
Right.
So you're saying like balance, like so somebody can't stand up because they're myelopathic? Honestly, physical exam, myelopathy, you get a ACDF. You fix the myelopathy. You didn't see that coming, did you? Next. Yeah, of course. I think you make a great point. Yeah, I'm certainly not that far down the road, but I think that's probably like, yeah, next phase is like to look at that too. Yeah, good point.
Quick question. So if you don't have a gait lab, have you done the frailty test, like get up and go and grip strength and all that? Is it correlating to these
Yeah.
or not?
Yeah, the get up and go is like exactly but that's the first part of the get up and go is that chair thing. But also the frailty stuff, I collect a frailty phenotype. It's just a 5-question frailty phenotype on my patients, like how active you are, is pretty predictive, like of who is weak and who isn't. Yeah. Honestly, I think you can just, like now that I've done this, I just look at the patient and be like, which category are you in? But anyway, I hope we're going to move a little bit from all the radiographic parameters to maybe some sexier functional stuff. It's just hard to measure. So,
All right, one last question. Say.
Yeah, Shane, I think this level of phenotyping is really important considering our adult forward patients. You talk about being able to predict complications or junctional troubles. How does this guide you in terms of what levels to use? For example, the stiff person would be more likely to use longer or shorter, knowing that they're more likely to fail.
no, I think that if the patient's able to control it, so if they're really rigid, they're stiff, right? They can't move at all. I think you don't have to necessarily go long because they've already fused. I think that the patients who have a very mobile segment, who are weak and have stiff hips, so now stiff hips, short hips, those are like really likely to get PJK and fail. I think the people who are active and strong and have good mobility, they're okay. So I think that's basically how I'm trying to think about it.